Okay, professors, we are ready to begin. Will you please announce the beginning of our meeting?
Me.
Yeah, you are the
Okay.
professor. Yeah, we owe you
Okay,
a
thank you so much.
presentation.
Thank you very much. So this is the so-called Bantane and the Basque the web seminar. Thank you very much, Kuwayama Sensei, and also the other speaker from the Tianjin, Dr. Nai. And I think today's the meeting is focused on the aneurysm, and also the Kuwayama Sensei is going to talk about the overview. It's very interesting. So we are very much looking forward to your lectures. So,
Okay,
President Sensei, thank you very much. So please, you can start.
okay, thank you, professor. And we have two presentation with two speakers. One is from Japan, another is from China, and we still have two discussants. So let's begin our meeting and begin the first presentation, and we will discuss after each presentation. So because we have 1 hour meeting, so each presenter could have 15 minutes, and we can talk, discuss for another 15 minutes. And so it's time to begin. Thank you, all the colleagues and the audience. Professor uh, Kuwayama, will you please begin your presentation?
Yes, thank you.
Please, please.
All right, just a moment.
Okay, please start your PowerPoint. Yeah.
So, this is my talk. Today, I'm going to talk about the overview introduction of the recent neuroendovascular treatment. And this is the first talk of our IVL lectures by Team Kuwayama.
Okay.
Okay, so this is a photo of Team Kuwayama in, maybe this is in Dhaka, Bangladesh, this year. And this is
the direction to the
a movie to show about the hands-on workshop. Maybe in this as a Tashkent. I think this is Tashkent. And we are conducting many neuro or interventional hands-on workshop in mainly in Asian countries. So, do you know this professor? His name is Professor Egas Monitz. He's the first man to conduct the diagnostic cerebral angiography in the world. It was 1927, 100 years ago. He was also a Minister of Foreign Affairs, and he got a Nobel Prize by lobotomy. And I will talk about the paradigm shift in the field of neuroendovascular treatment. The first paradigm shift is, of course, GDC development in 1991. So since this GDC, we can treat patients with the coil treatment. And the second one is the ISAT trial. This trial proved the efficacy of the coil treatment in the patient with ruptured cerebral aneurysms. And third one is flow diverter like pipeline or web. And we can treat very large or giant aneurysm by these very effective devices. And recently, we can treat the dural AB fistula very effectively by Onyx TAE or Onyx TVE. So let's begin with the aneurysm treatment. In Japan, 8,000 certified neurosurgeons we have, including 2,000 certified endovascular neurosurgeons. In Japan, neurosurgeons are doing endovascular treatment at the same time because we have very few number of neuroradiologists in this country. And thus we can do comprehensive treatment only by neurosurgeons. So now the 45% of aneurysms, ruptured or unruptured, are treated with clipping, and 55% of aneurysms are treated with endovascular treatment in Japan. This is the example of setting of the neuroendovascular treatment for the cerebral aneurysm. You can see two guiding catheters in the bilateral groin puncture, this one and this one. And you can see 1, 2, 3 microcatheters from these guiding catheters. So we can use two microcatheters and one microballoon, or one microcatheters and two microballoon. So this is the patient, example of patient. You can see very, very tiny aneurysm in the bifurcation of the vertebral artery and the pica. And the aneurysm arising from the origin of the pica. This is ruptured aneurysms. And diameter of this aneurysm is less than 2 millimeters. This is a very difficult aneurysm to treat by coils. Rotational angiography. And this is a balloon catheter to protect from rupture of the aneurysm. This is microcatheter. And now the microcatheter gets in the aneurysm dome. See this tip of the microcatheter and the dome of the aneurysm. You can see how small this aneurysm is. And this is angiography, and I start to insert coil, very, very tiny coil, into the dome of the aneurysm. But you can see the difficulty of inserting the coil into the very small aneurysm dome. And sometimes get out of the aneurysm dome like this. And I tried again and again. And finally, the coils are very, very well uh, inserted into the aneurysm dome. Maybe this is a final trial. So this is the tail of the coil, and I can cut the coil, detach. And you can see final angiogram. Oh, a very successful embolization. And next one is a very ugly looking dissecting aneurysm arising from the basilar trunk. You can see large ruptured aneurysm, looks like mountains. And if you treat this kind of aneurysm, you will need definitely a stent assist. Vertebral angio. This is a measurement. Go with the stent catheter into the distal PCA, and go with the aneurysm dome with the another micro catheter. I start to open up the stent from here to here, and here I put coil into the aneurysm dome, and I start to open up the stent like this. Then I start coiling again. You can see the stent is effectively protecting the coil herniating out of the aneurysm dome. This is a stent line. And I put many coils into the aneurysm dome. And finally, this is a final coil. And I finish opening the stent from here to here. Here. Now the detachment of the stent. And this is final angio. This is rotational fluoroscopy, and you can see how effectively the aneurysm dome was packed with coils. So next is the flow diverter. You can see a large, very large aneurysm in the cavernous portion of the internal carotid artery. Here you can see aneurysm. I go with a microcatheter into the distal ICA. Distal ICA. This is a distal access catheter, and this is a guiding catheter. And I start open up pipeline coming here in the distal portion of the internal carotid artery, and I start to open pipeline from here. And sorry, this is the final picture immediately after treatment. And after 1 year, you can see aneurysm no longer. Another case, 84 years female, cavernous sinus, cavernous portion, large aneurysm. Diameter is 20 millimeter. And this is pre-treatment. And this is DSA 4 months later. Very, very tiny aneurysm is rest. And after 1 year, aneurysm was gone. Second talk is the revascularization, acute phase and the chronic phase. At first, I will talk about the mechanical thrombectomy for acute stroke. This is a very recent hot theme in the field of endovascular treatment. See this patient. It's acute occlusion of the middle cerebral artery, and the clot was retrieved by stent, and this is after treatment. These 5 or 7 studies are improved. I'm sorry, 5 or 7 as clinical trial proved the efficacy of the mechanical thrombectomy in 2015, 10 years ago. And finally, this is a meta-analysis by Elmes. It proved NT and number needed to treat is as small as 2.6. It means this is a very, very effective treatment. And recent data shows the thrombectomy, even in a patient with a low aspect, is still better than best medical treatment. Low aspect means modified Rankin scale. Oh, I'm sorry, not modified Rankin scale. This is I'm sorry. This is not modified Rankin scale. Score, yeah, CT score of the ischemic lesion from 3 to 5. And 2 papers coming from China proved the efficacy of the thrombectomy of the basilar artery, posterior circulation. But unfortunately, middle basal occlusion, like M2, M3 occlusion, is not proved because of many complications with hemorrhage. Thus, it is called now MEVO shock. Very recently, this is April data of this year. Let's talk about the carotid artery stenting. These are very old data, and only Sapphire and Crest proved the effectiveness of carotid artery stenting in the world. And especially Crest proved the efficacy of the CAS in normal risk patients. But in detail, thromboembolic complication in CAS is more than in CEA. But the acute myocardial infarction in CAS is less than CA. Thus, the result was even in these two groups. This is treatment of CAS. You can see a very tight stenosis in the origin of the neck internal carotid artery, stenting and post-dilatation, and this is final angio. So my final talk is efficient. This is dural AV fistula in the cavernous sinus. You can see right external feeding pedicle come into this very limited portion. This is called venous collector, and you can go into the microcatheter into this very tiny portion and put some coils. Then the AV shunt was gone. This is called selective or super selective transvenous embolization. So the transvenous embolization is a standard treatment in the lesion of the cavernous sinus. But in the lesion of the transverse sigmoid sinus, nowadays TAE bionics or TVE bionics is the standard treatment. So this is, you can see isolated sinus. This is AP view, and this is lateral view. You can see isolated sinus here, and vigorous cortical reflux here. And I go with the microballoon catheter into the distal occipital artery, like this. And this is microangio from the balloon catheter. And I put onyx from the distal occipital artery, and the onyx get into the involved sinus like this, and start to pack the isolated sinus. You can still see the sigmoid sinus here, and I continue to push onyx to the proximal sigmoid sinus. Then the fistula was gone. This is final angio. You can see dural AV fistula no more, like this. Okay, thank you very much for listening.
Okay, thank you,
Thank you.
Professor Kuwayama. You give a very awesome presentation talking about almost all the endovascular treatment for cerebral vascular disease. So we have some participants and we have two discussants. We can discuss for about 10 minutes. So any questions from our audience? So Professor Liao from Huashan. Professor Liao, are you here?
Yeah, I'm here. Thank you, Professor Yang. And thank you, Professor, for the great presentation. It's very informative and inspiring, and very successful and interesting cases. And Professor Kuwayama,
Yes.
I have one question for you. Can you hear me?
Okay.
I wonder, what's your experience in the flow diverter in the treatment of the blood blister aneurysm?
Blood blister aneurysm.
Yeah. It's full of challenge.
Actually, I have no experience in the to use the flow diverter, but usually I in recent years I use very tight mesh stent like Elvis, 2 Elvis, 3 Elvis for the blister-like aneurysm. And the flow
With coils?
is not proven to use. It's not in Japan. So we can't use it.
I know. Do you use the several Elvis with coil or without coils?
Yes, yes.
With coils.
Maybe 2 or 3 lbs is equal to flow diverter like a pipeline.
Yeah, I know. Combined with coils or just stents?
Yes, yes, of course.
Ah,
Small coil, small number of coil.
okay. Thank you.
Okay, thank you, Professor Liao. Do you have more comments?
Yeah,
Dr. Ben?
Yeah,
question?
Professor
please.
Ben, please.
Yeah, thank you, Professor Kuwayama, for your great lectures, and nice to meet you again.
Thank you
And
very much.
yeah, I would like to ask about for the use of the in acute setting like rupture and aneurysm. So do you prefer to do the for wide leg aneurysm? Do you prefer to do the stent assist
What kind of aneurysm?
in rupture aneurysms?
Ruptured aneurysm.
Rupture, yeah, rupture.
Yeah. So would you consider doing the stent for the minor aneurysm? Would you consider doing a stent assisted coiling and with the antiplatelet, or would you defer the stenting part into a second stage surgery? So what is your opinion?
Are you talking about ruptured aneurysm or unruptured aneurysm? Ruptured.
Yeah. Would you put the
Subarachnoid hemorrhage?
subarachnoid hemorrhage? Would you put the stent with the antiplatelet?
Oh,
You do it.
okay.
You do the coiling first, and then
If
stent
we
the
need stent in the patient, okay. If we need stent in the
yeah.
subarachnoid hemorrhage patients, we
Mm.
need antiplatelet therapy treatment. Antiplatelet therapy.
Yes.
Yeah.
Mm. Immediately before treatment. So I will usually give patient aspirin and clopidogrel after general anesthesia from the nasogastric tube, and then use stents and coils.
Mm. So how about would you is there any situation that you would do the coiling first and then do the stent at the later stage?
I
Yes.
see. I can put the small number of coil in the bleb, and after that, in the chronic stage, I can put stents and coil in the same patients. Or I can use flow diverter for the aneurysm in the chronic stage.
I see.
Mm.
Thank you.
Yes,
Thank you so much.
I think Dr. Ben is talking about the gel techniques. The gel technique. Maybe there are two methods for coiling a rupture aneurysm with the
Yeah,
assistance of stent.
like a staged treatment,
Yeah.
right?
Yes.
Okay.
Mm.
And we still have another discussant from Thailand, Professor Warlax. Maybe I cannot find her picture in our panelist.
So she's
Maybe.
not here. She
Yeah.
cannot join.
Okay. Professor Kuwayama, may I
Yes.
have a question? Yeah. My first question is that do you operate or do open surgery for your aneurysm patients? Or
For
you?
myself?
Yeah. By
No,
yourself.
I no
Oh,
more do surgery, open
Yeah.
surgery. My colleagues
Yeah. Also, I
will do
see that.
instead of me.
You do endovascular poorly.
We are team. Yeah, right.
Yeah, I see that. And what's your opinion for young generation neurosurgeons to be trained? These matters.
Okay. In young neurosurgeon, it's better to do
Yeah.
both hand. I mean, surgery and vascular surgery.
Yeah.
Open
Okay.
surgery and vascular surgery. It's better, much better. But I'm very old man. I started this field maybe 35 years ago.
Yeah,
So at
yeah,
that time, I was so busy to do this neuroendovascular treatment, and I gave up open
Mhm.
surgery.
yeah,
But recently, young neurosurgeon can do both, I think.
yeah, yeah. Yes. So I'm very agree with you
Yeah.
because vascular surgeons are developed very fast in
Mhm.
the area. We can
Yeah.
treat special vascular disease, and we don't have time to treat tumor, trauma, spinal,
Hmm.
and so many other disease. If we only treat cerebral vascular disease,
Yeah,
uh,
yeah.
either open surgery or endovascular are our weapons. We can we have more weapons. We can achieve more victories.
Mm. I completely agree with you.
Thank you.
Okay.
So
Thank you very
let
much.
it's time. Let's go to another speaker.
Okay.
Another. Okay. Thank you, Professor Kuwayama. Thank you very
Thank you.
much.
Thank you very much.
Okay. Uh, Professor Zhang, are you
Here,
ready? Are you ready?
ready,
Yeah,
ready.
Professor Zhang is uh, maybe he is a vascular surgeon and can have the double techniques, open surgery and endovascular. He's a very skillful endovascular surgeon in my department. So today, Dr. Zhang will introduce his presentation of uh, treatment for very tiny aneurysms. So, Dr. Zhang, please. Dr. Zhang, please
Here,
uh, start your presentation. Okay.
okay. First, thank the Professor Koyama. He gave me he gave us a good review of the history of in treatment aneurysm and AV fistula. I learned a lot. Now I will share our treatment for small brain aneurysm. For brain aneurysm, I think we all know there are some complicated aneurysm like wide neck or shallow dome, a small aneurysm or tiny aneurysm, or bifurcation aneurysm, and very tiny, plastic like aneurysm. When this kind of aneurysm are small, I think the treatment are more difficult. Now share a case and the experience like this. This is the first case. This is a male, 49 years old, and headache, not wrapped, unwrapped ACAM aneurysm. In this case, we use the stainless steel coiling to treat this kind of aneurysm. Sorry. Oh, this is ACAM aneurysm about 5 millimeters big, and we can know the first the big flow is from the left. The left A1 is big, and the right is small and wide neck. This patient refused to the open surgery. They want to choose the endovascular treatment. This is DSA. As we can see, the left The left C1 IC is tentorial, and the aneurysm is here. So what of the what operation strategy for us? We think there are two options. One is we use the Y stent to assist the coil, and in this way we can perceive the ACAM artery. But this technique is a little bit difficult. Another option is sacrifice the ACAM artery. Just use single stent to assist in the left ACA. Like this, we put a stent from the left A2 to left A1. Then another question is the priority. How to coil the aneurysm? We first to coil the Dofter sac or the can aneurysm. We all know the Dofter sac is more dangerous. So our plan is to put the first coil in the can aneurysm to become a blasted. Then put the second aneurysm and the other aneurysm in the Dofter sac. Finally, to treat the aneurysm. The ICA is tentorial, so we use the navy. Then, as our plan, we put a stent in the left A2. We use the semi-deploying technique. Then we put the first coil in the aneurysm to become a blast cage. This is the second coil. We put this coil into the Dofter sac. This way we is more safer. If the aneurysm is when the aneurysm ruptured in the operation, we can ablation the coil quickly. After the second the coil, then it's more then it's easy. This is the final this is the final angiography. Now we can see the all aneurysm was embolized. The right ACA is okay. The blood flow is okay. The second case is ruptured ACAM aneurysm. For this patient, it's a female, elder age, 4 years old, and this is ruptured with high level Hunt's grade, full grade. We can see the blooding is much. In angiography, you can see the aneurysm is a ACAM aneurysm with a soft shake. I go with a microcatheter to the aneurysm. The first coiling, we use one coil into the soft sac and the can aneurysm. This is the first coil. We can the parent artery is okay. Then we put more coil into the aneurysm. Then we use 4 coils embolize the aneurysm. Because it's a high level, the patient goes through the hydrocephalus, so we do the shunt lately. Finally, the patient recovery very well. This is 3 months. 3 months. This is 1 month after operation. This another case is also a ruptured ACAM aneurysm. Also a high elder age female, 70 years 8 years old. This is a small aneurysm, about 3 millimeters large. This is the post anterior valve. Right A1 is big, and the left A1 is smaller. So the neck is faced to the right A1. So we plan to ablate the aneurysm from the right side. As planned, we the 2 catheter in place. One is for coiled aneurysm. Another is to for stent. But this case is not frequently, and there was an accident. The coiling, the first coil unwinding and released. We can't withdraw the first coil, because half in the aneurysm and the last in the right A1. We want to use the Max wire to withdraw the coil, but unsucceed. So there's no way we can just put the first coil like this. A half of coil in the parent artery. but we can see the blood flow is okay. So next, we used other coils to ablate the aneurysm. Finally, full coil ablates the aneurysm. This is the CT scan after operation, 5 days after operation. We can see a part of a coil in the beyond the aneurysm in the parent artery, but no infection. We perform the lumbar puncture and continue drainage for the patient. At the same time, we provide the antiplatelet therapy with tirofiban and aspirin. This is 1 week after operation. And no hydrocephalus. No infection. The right frontal lobe is blood. Damage the lobe, not the infection. This is 1 month after operation. This is 1 month CT. This is the patient. 1 month. Can speak. This is 2 months. Walk, supported by his son. This is case 4. Another ruptured aneurysm. This is bacillar type aneurysm. We use the stent assist. Hunt his 3 or 4 plus. This aneurysm is interesting. With 2 labs, not can aneurysm and as parent shack. 2 labs. The right lab with doctor sac. I think the right one is bleeding part. Divided 2 labs. Both is tiny, about 3 millimeters. We can't ambulate the whole aneurysm by 1 coil, so we can just ambulate the right one first by stent assist. Of this like this, the left is the right one. So we withdraw the catheter and go with in the right part. And use coil to ambulate the right lobe. We use the small coil, 1.5 by 2, 3 coil to embolize the right part. This is the final angiography. We also perform the lumbar puncture and continuous drainage for the patient. Patient recover well. This case is a ruptured pecum aneurysm. She is a young lady, 37 years old, with an ample pecum. We can see the aneurysm is very tiny, and he's not from the ICA, but from the pecum. Here's pecum. We don't use the Maxwell to put the catheter into the aneurysm, and to shape the catheter, then use the catheter alone into the aneurysm. I think it's more safer. This is calling the because it's so tiny, the coil is difficult to go within the aneurysm. So we do it very slowly. Finally, we embolize this aneurysm. We shape the patient recovery well. This is another case. This is an unwrapped tiny aneurysm. It's pK1 aneurysm with 2 labs. A female, 66 years old. We do the MATA test, but no right P1. The aneurysm is like this, 2 labs with a big pecum. The patient refused do the craniotomy operation. So finally, we do the endovascular. The aneurysm is about 3 millimeters. So we use the two microcatheter technique. We into both lab. One is in this lab, another is in this lab. We delivering two coils at the same time. Then to generate compressed force to make the two coils stable in the aneurysm, thereby encoding the aneurysm. This is the final angiography. There's another case is of ophthalmic segment aneurysm. Also like a BBA aneurysm. This one I use the flow diverter. So for ruptured aneurysm, what is more better, coiling or clipping? I think this depends on a lot of factors, location, big or small, bifurcation, technical difficulties. For now, the craniotomy for aneurysm clapping is more how to say the damage is very small. In our departments, we use the the small incision and keyhole craniotomy, keyhole approach, like this. Like this one, this is ophthalmic aneurysm. We drilling the APC, small incision, and keyhole.
Okay, Dr. Zhang, please, there's a time limit. Please
okay.
Finish it very quickly.
Okay, this is a finish, the final image, clipping the aneurysm. This is another one, the rupture. This is summary. I think open surgery and interventional technical, each way has its own advantage. Neither technical can replace the other. For this case, like BBA, high-level Hunter's patients or posterior circulation aneurysm, like basilar aneurysm, or advanced aged combined with poor physical foundations patients. These situations are more suitable for endovascular treatment. And other like arterial toroidal artery aneurysm, or aneurysm, PCAM aneurysm with embryonic PCAM, or bifurcation and tiny aneurysm, a ruptured small aneurysm with a hematoma, more suitable for craniotomy treatment. Thank you for listening.
Okay, thank you, Dr. Zhang. You gave some very difficult cases for endovascular treatment. So, because the time is very limited, let's discuss with 3 questions. Professor Liao, are you here? Liao,
Yes, Professor.
please give your comments,
yeah.
please.
Yes, actually, thank you, Professor Zhang, for the great presentation, and all the cases presented are well treated. Actually, I have 2 questions for you. The first is, what kind of stent do you recommend in acute phase? Which kind of stent is your recommendation? And the second one is in the coiling, during the coiling of the small aneurysm, is there differences between 2-dimensional and 3-dimensional coils? And what's your experience? Thank you.
The first question is
what kind of stent?
What kind of
in
stent?
acute stage? What is your recommendation?
Stent.
Yeah,
what kind of stent?
Like Atlas or small
Yeah.
mesh for your like Elvis or Leo, or and what's your experience?
In fact, in our department, we use a fail kind of stent. We use most is the EP enterprise stent. I think the EP2 is a good stent. We can in most situation, this stent can assist the coiling.
Yes, I agree with you. Yes, I think the ischemic complication may be lower with this kind of stent.
Yeah. But for the small, but for the bifurcation, or for the how to say, for the big PCAM, we can use the a little baby, or the small stent. It's more suitable.
Yeah.
We can use this small stent to do the Y-shaped or Y-shaped stents. We use both stent.
Thank you.
Another question.
Next question 就是2D 和3D 圈有差别吗？就是我two kind of coils, because I have limited experience about this. Do you think it's reasonable? Maybe the 2-dimensional coils maybe with less risk, maybe safer, or I don't know.
Yeah.
I just want to know your experience.
This way, for coiling, in my parents, I like first to choose the 3-dimensional coil to do a basket. Then use the 2-dimensional coil for coil. Yeah. Most of the way like this.
Okay, I know. Thank you.
Okay, thank you, Professor Liao. You asked a very key questions. Thank you. And is there any question? Yeah, Ben, please give your comments, Dr. Ben.
Yes.
And thank you so much, and congratulations to your experience in managing the cerebral aneurysms. I have a question about the technique for those clipping of the IC aneurysm. I saw you use mainly the intradural anterior canaldectomy. So what is your preference between the intradural or extradural anterior canaldectomy? So what is the advantage? Because I think both of each is can be achieved through the mini-terional craniotomy. Another thing is about I saw the clipping cases are mainly unruptured cases. How about the ruptured IC aneurysms? Would you also discuss for the clipping? How to choose between the endovascular or clipping in the ruptured IC aneurysm?
Oh, okay.
Okay.
For rupture aneurysm, which way is better? Like this? In fact, most rupture aneurysm, we can, like the Professor Yang and Professor Kuwayama says, we can do open surgery and endovascular surgery. For young doctors, I think both hand is a good option. That's like the case I conclude. Some case is better, is suitable for open surgery. Some is suitable for endo surgery. That's like the conclusion.
I mean for the ICA aneurysms, the ICA aneurysms.
ICA aneurysm.
Yeah, I saw the clipping cases are unruptured. Yeah. So how about the rupture? Would you also any experience with the ruptured ICA aneurysm for clipping?
I think Dr. Ben is talking about the very small aneurysm on the IC, and we clip Dr. Zhang present with clipping or very tiny aneurysm. If it's ruptured for the very tiny IC aneurysm, open surgery is sometimes is very dangerous, because when you open it, when you expose the internal carotid artery, there may be a massive disaster bleeding in the field. So if you want clipping it, when we, for example, when we clipping for the blood blaster aneurysm, we need have control in the internal carotid artery in the neck, and we need some prepare for some weeping and the stitches and even high flow bypass, and this we have to prepare everything for a very small internal carotid artery, especially like a blood blasting aneurysm. Uh, I have the very very bad experience of one patient with these situations, and I have to perform a high flow bypass because I cannot whip it. I cannot stitch it. When we put clippers on the internal carotid artery, it's occlude totally. So I have to perform bypass. So that's very embarrassing. So it it maybe it's for these situations, maybe endovascular is easier and maybe more safe and more suitable beginners. So I think that's a very difficult situation.
Yes.
Okay.
Thank you so much.
So Professor Kuwayama, will you please give a comments for the small aneurysm? Professor Kuwayama? Are you here?
Yes, I'm here.
Yes,
For
please
very
give a
small or
comment.
tiny aneurysm, and the vascular
Yeah,
treatment is very, very difficult or risky. And
yeah,
sometimes open surgery is even safer. But maybe 80% of the ruptured cerebral aneurysm can be treated by endovascular treatment.
Yeah.
And in 20% of aneurysm, we have to do open surgery. So in this meaning, I told you that we need both hands, open surgery and endovascular surgery. And open surgery is not disappear, I believe.
yeah.
And for non-ruptured aneurysm, we do not treat very small aneurysm less than 5 millimeters.
Yeah.
We usually treat 5 or larger aneurysm, unruptured aneurysm in Japan.
Yeah. But in my city, and we always meet some patients with very small aneurysm, but they ruptured. So
Yeah, usually
small rupture,
ruptured ACOM aneurysm is very small and very
very small. Yeah, yeah.
risky. And sometimes it's a pseudo aneurysm.
Yeah. That's the more danger.
Very dangerous one.
Yeah. So, what's your opinion if you say unruptured, very small aneurysm? What's your recommendation for your patients? And because we have to the responsibility to tell the patient what's the risk of surgery and what's the risk for follow up.
No, for the unruptured aneurysm,
Yeah, for
we
unruptured.
just follow the patient. We just follow the patient. We will not treat them.
How long you follow up for the how long?
Every year by MRI.
Yearly, every year follow up.
That's once a year.
Once time a year. Yeah.
Mhm.
So, okay, thank you. So,
Thank you.
thank you, Professor Kuwayama, and we have a very warmly discussion. And Professor Raja, our organizer, are you here, Raja?
Yes, Sensei.
Yeah, Raja.
The organizer is
Thank you
Professor
very much.
Kato. I am not the organizer.
So please give
I'll ask
comment.
one question to Prof.
Okay,
Naichan.
please.
The third case you showed about basilar tip aneurysm, that
Yeah.
patient had a intraventricular bleed
Yeah.
and mild hydrocephalus. What did you do with that? The third
Dr.
case.
Zhang? Yeah, third case. Dr. Zhang. Dr.
Okay.
Zhang.
哎，
第三个病例出血，术中出血了啊。Your third case is bleeding. What's your technique to stop the bleeding to save the patient?
It was intraventricular bleed with mild hydrocephalus. What did you do with that patient?
No bleeding.
What's your third
This
case?
one.
Into the ventricle. The bleeding was into the ventricle. The basilar aneurysm.
基底动脉那个脑室内出血了。
哦，这第三个是这个是前交通这个
Basilar artery， 基底动脉的
basilar
basically artery aneurysm ruptured with ventricular
This one?
Yeah, this one.
Yeah.
There is blood in the occipital horn of the lateral ventricle with mild dilatation of the temporal horns with suggestive hydrocephalus. Did you do something for hydrocephalus or intraventricular bleed? EVD?
Lumbar puncture.
EVD.
And condition.
We do lumbar puncture.
Lumbar puncture. Okay.
Lumbar puncture.
Okay.
Yeah.
Thank you.
Okay. Thank you. Professor Raja, could you give some comments for this activity organized by ACNS?
The activities are all prime brainchild of Prof. Kato, And we are
Yes.
extremely grateful to Sensei Kato for organizing these wonderful webinars. It is like all the youngsters can join in, and the main person behind this is Liu Bun Seng, and Ben, of course, he is there. So I am extremely grateful to the entire team of ACNS, especially to Professor Kato. Thank you very much, Professor Shinu Wang, for chairing this session today. Thank you.
Yeah, thank you, Raja. We have so very awesome activities for under the ACS, and we all directed by our dear Professor Kato, and all the even in my city, young neurosurgeons, they think they learn a lot from ACNS. And the ACNS have held several meetings in China and in my hometown. It's our great honor to have these opportunities. So thank you very much to ACNS and to Professor Kato, Professor Liao, and Raja, all your effects and for organizing. And today we also want to say thank you to our our two speakers, Professor Kuwayama and Professor Zhang, and our discussants, Professor Liao from Huashan, Shanghai. And if Professor Kato here, well, I would like to invite Professor Kato to give final words for our today's education course. Professor Kato,
Yes.
would you
Okay,
please?
thanks so much. Yes, thanks so much. So I think as for the small type of the aneurysm, with the second speaker that he talks, I think of course that in Japan the size is more than 5 millimeter. We focus on many of the cases, but Dr. Yan and me is open surgeon, so we know the very small type of the aneurysm, size of the aneurysm is ruptured. So many cases we experience. Because not only the size, but also the shape and also the genetic or familial history. So many things is related with the aneurysm rupture. So I think not only the size, of course, mainly the larger one is we should focus on the treatment. And also the Koyama Sensei gave us a very nice overview of what happened in endovascular the world at my institute, almost disappearing of the open surgery because so many cases, the aneurysm cases are treated by endovascular, especially the web. The reason that we use so many web, even the MCA and also ICPC, for so many places. So I think how we can teach the young doctors to open surgery, because now the teacher class is they cannot teach the younger generation how to open the surgery. Of course, the Professor said the open surgery will be survived, but I think in the future, my wish is disappear of the open surgery of the aneurysm, I think. So thank you very much for everyone. It was very fruitful, the webinar. Thanks so much.
Thank you.
Okay, thank you, Professor. So it's time. Every time is very limited, and the time goes very fast. Let's see each other next time. Thank you, professors.
Thank you so much.
You.
Thank you, Professor
Let's
Yan.
go.
Thanks so
Thank you so
much.
much.
Thank you.
Thank you so
Bye-bye.
much for